Society US. Hello and welcome to the International AIDS Society USA webinar that will feature data from the 13th IAS meeting. We're really pleased to have you here. And I'm Trip Gulick from New York City, Weill Cornell Medicine. And I am joined by our speaker of the day, Marina Klein, who is professor of medicine at McGill University in Montreal. Let's start with some demographic questions. Hopefully you're seeing these displayed. And go ahead and tell us, number one, what is your academic training or background? You can see the choices there. Number two, how many individuals with HIV are presently under your direct care? And if you precept, you can count those. And number three, what proportion of your clinical time is spent caring for people with HIV? Okay, hopefully you've had the chance to answer those three. So and here we go. So the results show us 43% of you are medical doctors, 4% physician assistants, 10% nurse practitioners, 10% nursing professionals, 23% pharmacists, and a fraction of other people. In terms of how many people you care for, a third of you care for none. So 2/3 of you are caring for quite a few patients. And you can see we've got about a third of you care for more than 100 patients each. So very experienced group here. And then what proportion of your clinical time is spent caring for people with HIV? 2/3 of you spend some time. Over a quarter spend over 75%. So heavily involved with the care of people, 50% over half your time. So welcome, very experienced group. I think the meeting this year was in Rwanda, so many people did not have the chance to travel that far, particularly with current travel restrictions. So we're really pleased. Marina and I were both there. We said hello when we were there, and we're really pleased to be able to share the data with you today. So this was the 13th International IAS Conference, specifically focused on HIV science. And that's Marina and me. There you go. So this is the International AIDS Society USA, the IAS-USA. You can see that there is content on the web board, headed up by my colleagues Mike Sag and Marshall Glesby, who's here at Weill Cornell with me. And then the board members are listed as well. Dr. Klein reported her relationships, consulting for and grants paid to her institution from ViiV, AbbVie, and Gilead. I have no relevant financial relationships to disclose, and the planners and reviewers of the current content had no relationships to disclose. We do provide continuing education credits today, which is a great thing. And this activity is accredited for 1.25 credits. You can see the breakdown below. So we give CME for continuing medical education, ABIM mock points, which are important, and then nursing, pharmacotherapy, and pharmacy also receive an equivalent number of points. We're pleased to acknowledge the supporters of the IAS-USA, and you can see our platinum supporters are Gilead, Merck, and ViiV, and we appreciate their support. So how do we navigate the activity? We'll make this interactive today. So we will ask you some questions. So there will be polling questions similar to what we've already done. So I think you got the hang of it with the demographic questions. We also encourage you all to answer questions. The way to do it is to use the Q&A button, not the chat button, but the Q&A button. If you do submit a question, and we hope you do, please provide your name and institution so we know where the question is coming from. And we apologize in advance if we're not able to address all the questions in the time allotted. The chat will be open. That's for dialogue with other people. Again, if you're going to submit a question to our presenter, Marina, or to me, please use the Q&A function. And without further ado, let's jump right in. So again, I'm really happy to welcome Marina Klein, who was kind enough to put together everything we learned at the IAS meeting this year. And Marina, I'll turn it over to you, and thanks.
Thank you so much, Trip. Really, thank you all for attending. It's really a great pleasure and honor to be able to present you the data that were shared with us at the IAS 2025 in Kigali. As Trip already showed, these are my financial disclosures. And just in terms of learning objectives, just to say that really I'm focusing on having you able to describe research presented at the conference with a specific focus on prevention and management of HIV. Obviously, there's a lot of other material that gets presented at these conferences, but for the interest of time and given the audience out there today, I think these are the two areas that are of most value, and really a focus on the latest clinical applications of this data and how it could influence our practices. Understanding, of course, that this was a conference that took place in Africa, and there's a lot of data that relates to low and middle income settings. I think we can draw a lot of lessons from it, and it does have an impact on the work that we will do even in high income settings. So before we get started, we have a few pre-test questions. These look a little bit wordy, but I'll try to guide you through them. In a study, Breather Plus, a trial of intermittent therapy among adolescents, comparing kind of 5 days on, 2 days off, or weekends off, with tenofovir, disoproxil fumarate, and lamivudine dolutegravir, which is abbreviated as TLD. Which of the following were found? Low rates of adherence were observed on the intermittent arm as measured by MEMS caps. That's option A. Option B, most participants with virologic failure developed integrase resistance. Option C, intermittent TLD was inferior to continuous TLD. And option D, girls had higher rates of confirmed virologic failure to boys. So I'll give you a second to fill that out. And then we'll get to see the results. I'm not going to give you the answers right away to these questions. The object of this presentation will be to review the data that supports the answers, and then we'll have a chance to revisit these at the end. So here's the results, and we see that the majority of you, 74%, selected option C, intermittent TLD was inferior to continuous TLD. Okay, our next question is, we've seen many studies that have suggested that antiretroviral therapy exposure is associated with the rate of weight gain in people living with HIV. So which of the following statements is true about results that were presented at this conference? When switching from efavirenz-based triple therapy to a dual therapy with atazanavir, ritonavir plus lamivudine, it resulted in significantly less weight gain than dolutegravir-based dual therapy. Option B, among people with HIV and obesity, continuing integrase strand transfer inhibitor therapy resulted in a similar amount of weight loss as switching to doravirine-based ART. Option C, when switching from an INSTI-based ART to doravirine-based ART, people with obesity experienced more weight loss when they took a tenofovir backbone rather than a TAF backbone. And option D, a 12-week course of liraglutide, a glucagon-like peptide 1 receptor agonist, led to sustained weight loss and metabolic changes at 24 weeks. So go ahead and answer, and then we'll see the results coming up. They're taking time. And here we have a bit more, oh, there, I can see option D. So a bit more diversity in opinion across the spectrum, with the most popular choice being option D. Okay, so we'll get back to this as we go through the presentation. So IAS 2025, as we mentioned, took place in Kigali in Rwanda, which is truly a remarkable country, and it was a remarkable place to host this conference. It's a landlocked country, as you can see from the map, with a very difficult colonial and post-colonial history. And it really shone as a host. Trip and I were talking about this just before the session started today. It's embraced modernity and development, and that's sort of epitomized by this photo I took of the conference center. So that's what that beehive-looking structure is. That's where we got to spend our week in Kigali. It really has very high levels of security. It's clean, fantastic infrastructure, and really, truly warm and welcoming people. It was really a pleasure to be there, really a pleasant surprise, actually, I think, for most of us who had never been. But for me, this visit was really personal. I started my practice in Montreal so many years ago. And at the time, I took on a large influx of patients who were fleeing refugee camps after the genocide in Rwanda. Many of these were women. And I've been really privileged to care for them, to see them settle in Canada, to have families there in Canada, and with a remarkable resilience and humanity that I really had trouble understanding, given what I thought of the history of that country until I visited Rwanda. And without exception, they were so proud that the meeting was being held in their home country, and they really encouraged me to go and experience it for myself. So I think you can't really hope to understand Rwanda without knowing a little something about its history. And unfortunately, that history is of a terrible genocide. In 1994, in just 100 days, government forces, militias, and regular citizens carried out a genocide against the Tutsi ethnic minority population, which resulted in 800,000 to 1 million Tutsi and moderate Hutus being killed. And mass sexual violence was committed against Tutsi women, including their deliberate rape by HIV positive men. And these were some of these women that I have been taking care of for the last 25 years. In fact, it was one of these women who I still follow, who insisted that when I went to Rwanda that I meet her sister, who was a survivor of the genocide. And I was honored to visit a genocide memorial, which is really a fantastic place to really fully understand what happened during that period. There are 250,000 Kigalian citizens who are buried at that site who had been killed in the genocide. So she and her son, who was 7 at the time of the genocide, took us through this memorial, and it was such an amazing experience to hear about these atrocities and, importantly, the reconciliation that happened through their eyes. And I put some details here on the slide. I won't go through them all, but I think the main take-home point that really touched me most was how in addition to the International Criminal Tribunal that convicted many of the perpetrators of this genocide, there was this remarkable period of truth and reconciliation that followed with these community-based Gakaka courts, which were set up all across the country, where the perpetrators came face to face with the family members of people who were killed during the genocide, and they asked for forgiveness. And it was one of the ways that they could be reintegrated into society and that the society itself could move forward. And just before I move on to speak more about the conference, I want to leave you with this one quote, and this comes from a man who emigrated to Canada, and I think it is resonant today, and that's why I put it here. When people begin to hear speeches that dehumanize or treat people like animals, vermin, cockroaches, less than nothing, the alarm bells should go off. We begin to classify, to pit people against each other, us against them. These are signals that do not lie, and I think at any stage that leads us to genocide. We need to find preventive mechanisms, so it's important to react quickly and not wait until the bomb explodes. And Rwanda has made remarkable progress. And this was in a presentation given in the opening session by Sabin Nzamimana. He's the Minister of Health for the country, which really outlined how they have had a progressive, since this period in time in red here, where there was an interruption of health services, progressive and relentless path to reaching the Sustainable Development Goals of the UN, including reaching universal ART coverage in 2008. And this has led to a remarkable HIV response in Rwanda with a plummeting of new infections and a similar decline in the death rate from HIV in the population, such that Rwanda has now achieved the 95, 95, 95 targets, well ahead of many other countries in Africa and even in our own, with 230,000 people on ART at the moment. So that brings us to the conference, and really, there's a lot of topics, as I mentioned, that are covered at the conference. They're listed here. I can't do justice to all of them in detail, so as I mentioned, I will spend most of the time focused on prevention and treatment studies. But I think if we have a one-liner about what this conference was really about, it was really all about long-acting therapy. But before moving forward, I think it's very important to place this conference into context. It was important that it was being held in Africa because it's really the place which has now borne the brunt of the policy changes that are affecting us globally. And to mention a little bit about the geopolitical context and its impact, early impacts on the HIV response globally. So USAID, which is responsible for funding PEPFAR, one of the flagship programs developed by the United States under George W. Bush, has initiated more than 3.7 million people on PrEP between 2017 and 2024, which represents approximately half of the 8 million people started on PrEP globally. So a major contribution to the global HIV response. And as you can see here, it really started in 2021 and has had an exponential scale up until last year, reaching 3.7 million, and with the introduction of injectable PrEP at this point in time. But as we all know, things changed dramatically, and with the election of US President Trump, who issued executive orders pausing all foreign assistance in January, shortly after his inauguration. By February, there was a little bit of guidance from the US State Department, but that said that there would be a waiver that only included prevention of mother-to-child transmission services, but no other prevention activities would be permitted, such that all PrEP initiations were halted, and all support for that was also halted. And as we know, this is going to be transitioned over to the State Department by September 2nd, and really there has been no resumption of these services to date. So many of the studies at the meeting were really looking at the early impacts of these funding freezes. And just to show you one of these studies that was conducted in Mozambique, where you can see that PEPFAR accounts for 70% almost of all the funding that supports antiretroviral initiations. They have 2 million people who are on ART of the 2.4 million people living with HIV, and that 70% of that is supported or was supported by PEPFAR, with a smaller amount by the Global Fund, but very few other multilaterals or private sources were supporting ART. And as a consequence, with the interruption of funding led to huge interruptions in therapies, with a 39% or 10,000 people stopping ART in between April and May of 2025. And this is projected to have quite important consequences over the course of time. This is modeling that was presented in the same study, showing the numbers of new infections and projected numbers of HIV-related deaths that will start to increase almost immediately if this funding is not renewed or replaced by other sources. And it's estimated that 83,000 new HIV infections, or a 15% increase, will occur by 2030, and 14,000 additional HIV-related deaths. I think importantly also there's a reduction in monitoring. So viral load tests will be heavily affected, with 38% reduction in adults and 44% in children. And importantly, a loss of 20,000 highly trained healthcare professionals who are no longer going to be able to support the response. So that's sobering, information regarding the impacts on ART use. This study looked at the impacts of halting PrEP in sub-Saharan Africa on subsequent HIV infection. As you can see, ceasing PEPFAR's funding results in 700,000 individuals being removed from PrEP. It's really quite mind-boggling when you look at the actual numbers. This represents 94% of the current PrEP users. And Jack Stone and colleagues modeled the consequences of PEPFAR funding being removed for just 1 year. And it will result in an additional 10 to 15,000 new HIV infections over the next 5 years, and 85% of these will be among key populations. You can see that this is going to impact predominantly these 5 countries, and you can see how it affects the key populations disproportionately. This study, in fact, is quite conservative in the sense that it didn't take into account funding cuts beyond 1 year, and we think that those will likely be in place. Nor did it take into account the lost opportunity cost. As you saw, that PrEP was scaling up almost exponentially before the funding freeze, and would have likely continued to rise. And this isn't figured into these studies, so they are doing this in future analyses. So really, these sorts of issues were resulting in probably the only major protests that we saw during the conference, which occurred during the opening session in terms of the Minister of Health's speech, and really highlights who the people are that are being touched by these changes. These are individuals. These are people who've been living with HIV, who've been fighting to protect people with HIV and to treat them. But that said, I think we'll agree the overarching mood of this conference was really one of defiance, of resilience in the face of these cuts, and in creativity in response to them, and so as not to lose all the significant gains that have been made over the last decade. And it really was a forum to showcase to us how African science has really developed and how it can be important in informing global HIV practice.
And Marina, I'll just butt in and say the other thing I was really impressed with was that the Africans themselves were saying that if they had been given more notice, they would have been able to respond to these changes. And they recognize that they have their own responsibility to help support their own people. That was really illuminating to hear that.
Yeah, I think overwhelmingly, I think the idea that there's in-country response and an obligation to do that is really recognized and already starting to take place. So, and alternative funders are coming to the table as well. So I think positivity in the face of this crisis. Right, so I'm going to move on now to focus on prevention, which obviously is really, if we look at these countries who are coming 90, 95, 95, really that's our last sort of hurdle, is to prevent any new cases coming in if we can manage to keep people on treatment. So this study looked at the modeling the impact of lenacapavir. So there's a lot of talk about lenacapavir at this meeting for a good reason, because at the last IAS meeting we saw the results of the PURPOSE trials that really showed the potential for this injectable preventive therapy. And suffice it to say, there's quite a few numbers on the slide, but the bottom line here is if you could scale up lenacapavir by to account for up to 45% of PrEP use, we could avert a large number of cases in Kenya. This is about 12,000 cases, especially if it's combined with other family planning initiatives and care of people. This study also, for me, highlighted something I think that's important, is that how important it is to ensure coverage of PrEP among adolescent girls and young women who could, if they are prevented from becoming infected, could really have an impact on the global prevalence of HIV infection in the overall population, because there would also be no onward transmission in terms of mother to child transmission. We also saw more details coming out from those studies. So it was at the last IAS conference, as I mentioned, where Purpose 1 was presented. Purpose 1, to remind you, is a study in cisgender women and girls, which compared lenacapavir every 6 monthly by subcutaneous injection to FTAF or FTDF. And was remarkable, and it showed that there were no infections overall in the lenacapavir group. And this just drives that point home. But even if you look and zero in on the youth, there was no infections. In Purpose 2, which is in men and gender diverse persons, only 2 participants in the lenacapavir group had an incident HIV infection. In fact, there were only 2 infections in that trial, so they must have both occurred in the youth. And so clearly this is an efficacious prevention tool in a population who's really crying out for this tool, particularly in low and middle income settings. We also got more data on the safety of lenacapavir among pregnant and lactating women. I think it's important to highlight what a game changer the Purpose studies were in terms of bringing women into the study design, because it was recognized how important it would be for women who opted for this type of option to be able to continue it, even should they fall pregnant, to protect themselves from becoming infected and their future children. So while this is a relatively small number of cases of pregnancy, they're still quite sizable given the size of the study. So we had almost 200 cases in each of the 2 main arms, 100 in the other arm. And overall, the expected spontaneous miscarriage rate and incidence of congenital anomalies was within the expected background rate. Obviously, you can't say without larger data that this is entirely safe, but this is definitely reassuring with respect to pregnancy-associated outcomes. Just to mention that ViiV also presented registry data on CAB-LA exposure in 42 pregnancies, which has also shown no concerning signal. But I think the limited number of pregnancies reported in their study precludes really any definite conclusions. But on balance, I think this is looking very positive. One study that was sort of interesting and reported in the posters was trying to compare CAB, LA, and lenacapavir for PrEP. And obviously, this is a study that would never get done as a randomized controlled trial. It's going to be one of those ones that, we don't get these head-to-head comparisons with such effective therapies generally. So they leverage methodology from indirect treatment comparisons from other settings, and were able to adjust for the differences in adherent levels in the different studies. So just to remind people, these HPTN studies 083 and 084 were sort of the parallel studies to Purpose 1 and Purpose 2, and looked at cabotegravir LA for HIV prevention, first in cisgender men and transgender women, and the second in women. And just the long and short of it is really, in general, are likely to be very similarly efficacious. Clearly, there are going to be differences in implementation and potentially differences in persistence on these therapies that this study couldn't look into. But given the fact that injectable PrEP is so effective, there's still some potential limitations in terms of its expansion as a large-scale PrEP option because of the infrastructure that's required to administer regular every 2-month or every 6-month injectable therapies. So there was a lot of buzz about this study, which was presented in the co-chair's choice session, because of the potential for expanding future options to a long-acting oral PrEP agents. So this is MK-8527, a drug that's under development by Merck, a new oral nucleoside reverse transcriptase translocation inhibitor. It's a long mouthful. Which was basically a dose finding and pharmacokinetic study in people or adults who were at low likelihood of HIV exposure. They conducted this study in Israel, South Africa, and the United States. And you can see the dose ranges here from 3 to 12 milligrams compared to placebo. And this dose is oral medication taken once monthly, and it achieves very high levels. The dotted lines here are the threshold for protection. So especially the two higher doses, and this is at 24 hours after the first dose. So very quickly you achieve that protection, and there was no evidence that this accumulated over time. And they followed these people for 6 months with a monthly pill and showed good safety, tolerability that was similar to placebo, and importantly, no decreases in lymphocyte or CD4 cell counts. And we'll come back to that in a moment. But that was one of the concerns with another of their compounds, is islatravir. It looks like from the pharmacokinetic profiles, on this side, this is looking at the active metabolite in concentration in peripheral blood mononuclear cells, also showing no real accumulation. That this will go forward into phase 3 studies, which are beginning by the end of this year. They're called Expressive 10 and Expressive 11. I think, Trip, I think it was you who asked Ken Meyer, who made this presentation, what dose are they going to choose from this? And Ken was a little hesitant to answer directly, but this trial is listed on clinicaltrials.gov. And it looks like they're going with an 11 milligram a dose, which it's hard to decide why you would go with 11. Anyway, I don't know if you have any insights.
I don't, but it's splitting the difference, close to 12, obviously.
Yeah.
And Marina, just to emphasize something you said, I think with the new injectables, lots of excitement, but there is a group of patients who wants oral, and to have an oral monthly med would be a really nice benefit. And of course, what we need most is choice, and people may opt to swing back and forth between different therapies.
Exactly. And the other thing I think this kind of lung level above the threshold for protection suggests is that there might be some forgiveness of up to a week from the dosing intervals, which is actually another good potential quality of this development. Right. So moving forward to treatment, as usual at IAS, we don't see a lot of new molecules being presented. There was one, I'm not going to go into the detail. It's from a generic pharmaceutical on a new maturation inhibitor, but it's so early stage that I don't think it's that relevant to our practice. So I'm going to first by going over some strategies with existing ART regimens and then look at possibly some newer approaches. So, in the context where intermittent ART might be more convenient, better tolerated, and importantly, cheaper than continuous treatment, and may even be now necessary in certain countries, given the stockouts and potential for reduced funding, I think revisiting whether intermittent ART is a viable approach was worthwhile. And so this was a systematic review and meta-analysis that was presented by Fairhead and colleagues and looked at these major studies that have looked at this question. And patients included in these studies, just to say, all had long-standing suppression, excellent adherence, no prior genotypic resistance, and frequent viral load monitoring. And most of these are in high-income settings. And as usual with all meta-analyses, the results are driven by the largest study, in this case, the Quatuor study, which is an ANRS trial in France, which was a study, to recall, that was actually 4 days on, 3 days off, and could have a different third drug, NNRTI about 50% and INSTIs about 50% in that trial. Essentially, there's really no difference across these studies, quite a lot of heterogeneity, as I mentioned, with respect to what intervention was and what the treatments were in terms of their backbones. And really not a lot of failures, in fact, very almost identical, which was quite reassuring. In fact, that led in France to a recommendation in their guidelines that this is a strategy that could be considered. And just in terms of the thing that we get concerned about, emergence of treatment resistance at failure, basically very few failures. And in the cases of failures, yes, you did see some resistance, but very similar comparing intermittent with continuous treatment. And in fact, the continuous treatments had slightly more failures. And possibly that's because we all know people who are on continuous treatment don't necessarily take it continuously. And when they do fail, they are going to fail with resistance as well. So very reassuring. So with that in the backdrop, we had a presentation of a new study, the Breather Plus. So if you recall in that last slide I showed, Breather, the original Breather study was concluded there and showed no difference between the two strategies. That was a study using efavirenz based heart. In this study, this is short cycle therapy, which is 5 days on, 2 days off. So basically with weekends off. Comparing regimens with TLD, tenofovir, lamivudine, dolutegravir. It conducted in Kenya, Uganda, South Africa, and Zimbabwe. And just to say, the primary endpoint here is a confirmed virologic failure of RNA greater than 50 copies per ml. So quite strict. I mean, it's the usual one we use in many trials, but you can imagine if you stop a drug which has a relatively fast half-life, the possibility of a virologic blip, if the measures are taken shortly after stopping, could potentially favor the continuous treatment arm. Again, as most African studies, the majority were women. Interestingly, this study, in contrast to the other studies, showed that intermittent TLD in adolescents was significantly worse than continuous TLD by a 5% difference. And this crossed the non-inferiority margin, both at the 99 and the 95% confidence interval. There was, you can see this seemed to accumulate over time if you look at this Kaplan-Meier curve. The reason for this is not clear. There was really no heterogeneity in the treatment effect by site, by baseline age, or other characteristics that we could see. And interestingly, and this gets back to this question about the outcome that they selected, those who were on intermittent ART, and 9 of whom resuppressed when they switched to daily TLD, but 10 of 14 who did not switch back also resuppressed. And similarly, we had resuppression rates on the continuous arm when they were restarted on their TLD. So it suggests that maybe some of these were low-level viremias, and we don't have data about when the viral load measures were taken, i.e. was it Monday after the interruption, nor did they report the median viral load at the confirmed virologic failure. I asked about this, if they changed the threshold for the outcome to greater than 200, and apparently the results would be similar, though we don't have those results presented at this time, but they are being analyzed. And I guess reassuringly, really no resistance emerging. In fact, the only resistance that's really present were those that had resistance prior to entry into the study. So bottom line, it cannot be recommended as a therapeutic approach, I think, in this adolescent population at the time being, but I think there's some questions about how really important it is based on the outcomes that were used. What about 2 drug regimens? We're very comfortable using 2 drug regimens, I think, in high-income settings, but there's relatively less data in the low and middle income countries. And here's the Moderator trial, which is an ANRS-sponsored study, which addressed this question using a public health approach and two regimens which could be available. They took people who were living with HIV and suppressed for at least 2 years on either efavirenz or dolutegravir-based triple therapy and randomized them to either continue that therapy or to switch to dolutegravir 3TC or atazanavir-ritonavir 3TC. So we haven't seen many studies with atazanavir-ritonavir for a while, but that was an available option. And this is the 96-week data. And again, snapshot, algorithm, viral load, less than 50 copies as a primary endpoint. And as we can see, pretty much similar responses right across the treatment arms. This slight difference in percentage of 2.5% is really explained by having data out of window. So really no confirmed virologic non-response in any of the treatment arms. So very reassuring, meeting non-inferiority criteria, further giving support for the use of simplification regimens to 2-drug regimens in an African context. What I took from the study, which I thought was quite interesting, is what about the weight changes that occurred on this switch study? So we've seen a lot of switch studies from efavirenz-based regimens to dolutegravir or other INSTI-based regimens, but here we had the opportunity to look at what happened when we switched to atazanavir-ritonavir and 3TC. And interestingly, weight gain of comparable amounts between these two arms, slightly perhaps more on dolutegravir, but not statistically different. I think lending again more credence to the fact that this weight gain that we're observing is a consequence of switching off some weight suppressive regimens with efavirenz or TDF, for example, rather than switching on to regimens that promote weight gain. And so this was a bit of a surprising finding, but I thought was added to our growing body of evidence about the other studies that have reported on this. Okay. So moving to sort of more injectable options and understanding how they're performing in the real world, we had a number of cohort studies, some of which are supported by the ViiV, looking at how this combination is working in the real world. And this is probably one of the larger ones. This is the COMBINE-2 cohort from Europe, which looked at about 1,000 people who were virologically suppressed and switched on to cabrolpivirine LA. Notice that they have a very long duration of antiretroviral therapy prior to switch, no history of virologic failure or resistance from the history that's available, but not in everyone. Very good persistence, at least out to 12 months. Notice that there's only 49 people here at 2 years, so it's hard to actually evaluate at this point. And very few confirmed virologic failures. And 0.5% overall, with no clear reason for them based on subtype. We've had concerns about certain subtypes and failure on this regimen or a high BMI. But of course, at failure, as expected, low-level resistance to rilpivirine, and importantly, resistance to dolutegravir and bictegravir. So this is a consequence of failing this regimen, but it's reassuringly very rare. Another cohort study, this one from Germany, also industry sponsored by ViiV, looks at outcomes that kind of report, maybe a bit of a higher rate of discontinuation for non-virologic regions, about 10%, but still high persistence with virologic suppression. Again, the virologic non-response in about the same proportion, 0.6%. I think what this one particularly highlighted is the huge, overwhelming preference for staying on an injectable compared to the oral therapy, and the reasons for that being really around convenience, around worry and stigma, around not having to think about HIV every day. Very few, emergence of resistance mutations. About half of those who fail with virologic failure had resistance to NNRTIs and INSTIs, just like the other studies. And finally, another ViiV-sponsored trial, open label choice study, which looked at taking people who were suppressed on dolutegravir 3-TC and giving them the choice to switch after 16 weeks of observation. And overwhelmingly, people chose, about 90% of people chose to switch. The reasons that they chose are similar to what we reported in the previous slides, and really having patient-reported outcomes that suggest how this can really help with managing HIV and in their everyday lives. What about people who aren't so well controlled? I think if we ask that, who in my practice do I really want to use injectable therapies for? It's the people who have and struggle and have always struggled with taking oral treatments consistently. It's not that they have necessarily reasons for that. I see many people who come and they come to their appointments, they do their viral testing, but they just struggle to take it all the time. And they're often viremic, and it's often hard to get them completely controlled before making a switch. Can we switch these people who have suboptimal control? So there were a few studies that tried to address this. This is the Impala study, which builds on prior randomized trials that showed equivalent efficacy of switching oral ART among suppressed people in Africa. This is the phase 3 study among people who have trouble with adherence. So they basically selected people who had a history of detectable RNA of about 1,000 copies in the previous 2 years, despite being on ART, or had lots of loss to follow-up, or were unlinked to care, and they brought them into care. And then they supervised them, got them back on their oral regimens. And actually, so is this really somebody who's at risk for failure, but not someone who's actually failing at the time of switch, because they had to have a screening HIV RNA less than 200 copies at the time they could be randomized to stay on oral therapy versus switch to CAB rilpivirine LA. And just to say, this is done in a real world setting. There was no baseline clinical resistance testing. They did exclude participants who had evidence of either active chronic hepatitis B infection or core antibody positive without hepatitis B surface antibodies. And their primary endpoint was the same, FGA snapshot, less than 50 copies per ml. African study, again, high proportion of women, high proportion with high BMI. And most had prior NNRTI exposure. And the results are shown here on this slide. Excellent efficacy results with 91% in the intent to treat analysis on the CAB rilpivirine arm, 89% on the oral ART arm, with a conclusion at a 10% non-inferiority margin of CAB rilpivirine LA being non-inferior to maintaining oral treatment. And this was independent of BMI. So looks like a good option, very high retention, 99%, 98% of rejections were within window. And they had a confirmed virologic sensitivity analysis where they had a less strict difference, greater than 200 or greater than 1,000. And it was actually superior in that analysis. So looking very promising. I think people are, again, concerned about what happens when you fail virologically from these regimens. So I just put this table up here. It's busy, but as expected, we didn't have baseline testing, and they're going back to archive specimens to do so. And look at one of the failures actually already had high-level resistance to rilpivirine before starting. So this is the issue with when you can have this genotypic data available, really should strive to have it before making a switch, because these are the people who could potentially fail, as they did with both resistance, interestingly, was sensitive on their predicted genotype to rilpivirine, but resistant to cabotegravir. Again, small numbers in all of our treatments do have failures. The consequences might be greater when you lose these two classes, but hopefully we'll have options going forward. Some real world data that tried to also address this question in an oral presentation was from the OPERA cohort, which are a large managed care practice with over 150,000 people living with HIV included. They looked at their individuals who had been switched to cabrolpivirine while viremic being described as more than 50 copies per ml. So very, I would say, conservative definition of viremia. I don't know, Trip, in your practice, but I see a lot of people who blip around that level now, especially with the newer assays. And in fact, the median viral load at switch was only 120 copies per ml. So hardly people with very high levels of viremia, 68% of whom were on an INSTI before they switched. And actually, this study was got a lot of discussion, and I think some concern about the way it was designed. It's an observational study, and there was actually not as good control as we might see in some of the other trials. Only 85% with less than 50 copies within 6 months, and 12% never achieved less than 50 copies. So it's really need to dig in a little bit more, I think, in terms of what's happening here with these low-level viremias. They did have a few people who did have clearly virologic failure with some resistance, who maintained sensitivity to doravirine. So looking to the future, when we're going to have these failures, we're going to need new options. And I think also getting back to choice, other long-acting options that could either be oral are of interest. And so we heard more or longer-term data from this study presented by Jean-Michel Marina, looking at I can never say this, ulonavirine and islatravir weekly in virologically suppressed adults. As you know, so ulonavirine is a non-nucleoside reverse transcriptase inhibitor that retains activity against drug resistance to other early NNRTIs, has a resistant profile similar to that of doravirine. And islatravir is another NRTTI. And both compounds were put on development hold in 2021 due to islatravir-induced reductions in CD4 cell counts and lymphocyte counts. And so this is sort of follow-up data of that cohort that was in this phase 2 dose-finding study compared to bictegravir, FTC, and TAF. And what we saw is, as an antiretroviral approach, excellent efficacy that was persistent out to week 24 with almost 100% virologic suppression, no confirmed virologic failures. But we had the decrease in total lymphocyte counts and CD4 cell counts that were dose limiting in some cases and of concern. And so this data actually they presented to show what was the outcome of those people and after they stopped treatment. They looked at CD4 cell count recovery after a median of 25 weeks of switching to an alternative ART. And what you can see is, by and large, the trend is to recovery of CD4 cell counts, with the lower dose arm reaching the pretreatment levels. There's still a suggestion, I think, that at the higher dose, there's still some suppression of CD4 cell count that doesn't recover. And whether this is because there's concentration of the active metabolites in lymphocytes, it's unclear. The mechanism is still, I think, a little unclear. Anyhow, this means that they would not go forward with these doses. However, it was said that a new phase 2 study, which will evaluate a much lower dose of 2 milligrams, which is apparently supported by PK/PD modeling with lanaviridine at 200 milligrams each week, is going forward. So a weekly, I think we had some debate, Trip. I don't know what your thoughts are about what's the benefit of a weekly ART? Is there too much risk here with this indication? I don't know what your thinking is about
Yeah,
that.
no, I think it's interesting to see these regimens moving forward, isn't it? One pill once a week therapy. Who's the ideal patient for that regimen?
Yeah.
And talking to people and talking to patients, there are people who would like that as an option. So they would maybe take it every Sunday night or something like that. It's just echoing what we said before. Choices are good, and maybe this would be good. Someone going on vacation for a week, you just take your pill and then you go. I don't know.
Yeah, and I think there's some benefits too. We're all worried about these long tails when we have these injectable therapies. And here we wouldn't have such a long tail because of the half-life of this drug that if you have people who travel a lot or have, move around a lot and have to make adjustments to their lives, this could be an option. It also provides two new drugs that might work in the setting of someone who's failed some of these other, injectables. So a good reason to, I think, to move forward and see where it goes. Okay, so finishing that section, I'm going to move into the comorbidities field. And not a lot of data here, but I think the one, of course, that is always on their minds because we still are struggling with this. I know in my practice, like I mentioned, I have a lot of women who come from Africa. The amount of weight gain I've observed over the years in this population has been tremendous. It's very distressful. And we really want to have tools to manage it and understand better how we can avoid it. So this study is another large observational group trio, which has put out a lot of interesting studies over the years, which represents 12 clinics in the United States, looked at virally suppressed adults and did a case control approach where they looked at the people who had gained quite a lot of weight, more than 10%, and compared them to those who had really no weight gain. And just you can see the way the bar graphs are here, the distribution of people in the minimal weight gain compared to the significant weight gain with respect to INSTI exposure, NNRTI exposure, PI exposure, really no different. And similarly, with respect to TAF or TDF exposure, which kind of flies in the face of some of the stuff that we've seen or think we're seeing clinically. And so they did a multivariate analysis where they looked at predictors of weight gain over 3 years, and really clinical and sociodemographic characteristics were the primary factors that were associated with significant weight gain, and was a limited relationship or evidence of a relationship between those using, which ART regimen or which switch they happened. Again, some of this comes back to how these studies were designed. People with TAF exposure, for example, versus no TAF exposure or TDF exposure, when they switch, were actually less likely to gain weight than compared to their baseline. But you could say, well, they'd already switched and they were on TAF, so any weight gain associated would have happened already. So these are some things that are, have to tease out with more detail. But basically, those factors that keep coming out time and time again are Black race, female gender, in this case, being really more at risk, and maybe baseline CD4 less than 200. And so I think for me, this just goes back to counseling people need to expect that this could happen. Lifestyle changes need to be talked about early on, and we still need options. So what about some switching options? So if indeed, the TAF and integrase inhibitors do account for a lot of this weight gain, what if we switched to a regimen that had TDF and doravirine? So this was the DO-IT trial, which was ACTG 5391, which evaluated this question in an open randomized controlled trial. They took people living with obesity, defined as a BMI greater than 30, and who had been on a third drug of RAL, dolutegravir, or bictegravir with TAF FTC, and randomized them to switch to these 3 arms or continue their current therapy. This population, interestingly, 50% were female and 50% were Black. So it targeted the population for whom we need answers. Median BMI of almost 35, and very high amounts of weight gain in the first 3 years on their INSTI. And basically, the surprising factor is that everybody lost weight. This was powered to detect a 5% difference in weight gain, but all study arms lost weight, and any pairwise comparison between the study arms showed no difference. So what does that tell us? That tells us if you participate in a study around weight loss, you're sensitized to wanting to lose weight, and you will make lifestyle changes that will help you lose weight, but maybe changing the drugs is not going to do any good. So I don't know if it was you, Trip, or we all came up with this advice, maybe don't do it, is the answer from this trial.
Yeah, I was the co-chair of that study.
Okay.
And thanks for highlighting it here. We were hopeful that we would see something in the groups at highest risk for weight gain, and that's why we put enrollment criteria to assure that women and Blacks would be well represented. But as you point out in the overall analysis, or even in the subset analysis, there was no group that benefited by switching either to TDF or doravirine. So it kind of disappointing results. And
Yeah.
these are on the tail of another study that looked at switching similar group on an INSTI to a PI-based regimen and also saw no difference.
Yeah.
So disappointing that switching does not seem to be a very effective strategy at this point.
Yeah, and again, I don't know if we know why that is if once you've gained that weight, is it just really hard to lose it, or is this just not related to the drugs themselves at all, which is sort of emerging as I think the general consensus. So yeah, so what do we do then? Well, this trial tried to help us answer that question. And so this is liraglutide, which is a GLP-1 agonist. And it was an open label study in South Africa. So interesting, again, targeting a population which has had experienced high rates of weight gain on antiretroviral therapy. And they enrolled, it's a small study, only 40 people enrolled. 97% were women with a high BMI, 39. So these are people living with obesity. And with the treatment of 12 weeks duration and then stopping, there was weight loss, about 3 kilograms, and reduction in waist circumference, which is a good marker. Modest reductions in some of the metabolic parameters, really not a great difference in blood pressure or lipids. Yes, an HbA1c, but that's a 0.3% is not, arguably that huge. And once off treatment, this all starts to rebound. So short-term benefit, some improvement in depressive symptoms and sleep quality. And we know that these drugs are approved for people who have sleep apnea, for example. But obviously, this is something that needs to be continued long-term to keep the benefit going. Okay, so in terms of co-infections, there was relatively little data presented at this meeting, some on HPV, some on tuberculosis, and some on Mpox, but nothing on hepatitis C, which is my kind of area of interest, which is really interesting how we've moved sort of beyond hepatitis C already now that we have effective curative therapy. So let's going back to the Impala study, let's look at this question about hepatitis B in the setting of cabrapivirine, which is not active against hepatitis B. And they sought to see whether there was a risk of hepatitis B reactivation or, in fact, infection among people randomized to the arm with cabrapivirine. And lo and behold, just to recall, nobody in this trial was included if they had surface antigen or a core antibody without surface antibody positivity. So really a low risk for FB reactivation study. They saw really no reactivation, so that's not that surprising. But they saw incident hepatitis B infections with a number of people developing a new hepatitis B infection and none on the TLD arm. Only 8% of the people who were susceptible to acquiring hepatitis B had been vaccinated for hepatitis B. So basically the conclusion from the study is that we really need to strengthen our hepatitis B vaccination efforts, particularly among those switching to cabrapivirine, something that we probably don't twig to, I think, in clinical practice, as we're always focused on reactivation of people who already have hepatitis B. But in a high endemic setting where hepatitis B exposure is possible, I think we have to really consider this. What about tuberculosis? This was, I thought, a really nice trial because it asked a question that we often are faced with, which is if, when someone has or is suspected to have a concomitant tuberculosis at the time they're diagnosed with HIV, do we need to delay our HIV treatment until we know that they have tuberculosis or not? We always fear with tuberculosis and other opportunistic infections that we could, cause more harm by early initiation because of provoking iris. But this study randomized people to start ART immediately versus wait till the TB results came in. Large, highly powered study, and looked at a primary endpoint of virologic control for HIV. And looks like this approach were very similar, meaning it was starting ART first was non-inferior at a non-inferior margin of 10%, and really no increase in rates of death and no difference in the rates of iris in either arm, which gives, can see why being able to do everything initially when someone first presents could be a good option in a situation where this is a high endemicity for TB. And here's this shown in terms of the virologic outcome data. And so we can conclude that same-day ART initiation is not inferior to TB results first in a public health approach. And then finally, this study, the Unity trial, which was presented by Beatriz Greenstein, who was the chair of the IAS meeting from Brazil, really important because this is the only clinical trial that for clade 2 mpox that was completed at its fully powered level. And this study important to us in North America in particular, where we saw a great epidemic of clade 2 mpox in the last couple of years. And just to say, this took adults with mpox infection that was confirmed or highly suspected. Those with severe complications or severely immunosuppressed were not entered into the randomized part of the trial, and they were offered open label. These results were not presented at this meeting. The randomized trial results were presented, and in a really elegant study and analysis, I think it kind of closes the door on this option for treatment. Really zero difference between the two groups in time to complete lesion resolution, which was their primary outcome, nor was there any difference in any of their secondary endpoints. No difference in any of the subgroups that they assessed, either age, ethnicity, HIV status. There's a possible signal for a benefit in people with less than 200 CD4 cell counts, but not so few people, only 20. So we really need other options for this condition, especially as we're getting concerned about, new variants that could be more severe, and we need something to think about more prevention or early preemptive therapies with other strategies, I think. Right, I'm going to close just by highlighting a few important announcements that were made during the meeting regarding the WHO guideline updates, so major new policy updates. These are summarized in these two documents, which you can access at this website, and I've listed them here on this slide. But in detail, one of the major ones was, and a lot of talk about this, is that the inclusion of lenacapavir for PrEP as an option, in additional to the other options, oral options, and CAB-LA, the strong recommendation, and also a recommendation that you can use rapid diagnostic testing in the setting of PrEP initiation and around decisions for continuing and discontinuation long-acting injectable PrEP. They also released revised ART recommendations, which I think are quite interesting and reflect some of the data that was presented at this meeting. For example, dolutegravir 3TC as a simplification strategy, and adding cabrilpivirine as an alternative ART for switching option in people with suppressed viral load. Notice there's some other recommendations here as they modernize some of the options to come in line with data over time. And finally, TB and mpox, there's a recommendation around the preferred choice of 3 months of rifapentine and isoniazid for treatment of TB, prevention of TB, and for rapid initiation of ART in people who are diagnosed with mpox, who are ART naive or who've had prolonged treatment interruption. And finally, some discussion that was going around a lot as well was the recommendations around breastfeeding, which I would encourage you to look at because this has resonance here as well. But bottom line is really about choice, informed choice. And if choice is to breastfeed, there's very good guidance in this document about what prophylaxis should be provided to infants. And just to close, I'm not going into this data in detail, but one of the things my patients always ask me when I come back from every meeting that I attend is there a cure? How can I control this disease? Even though we have such great options now and choice for ART, really this is the holy grail. And we continue to learn from natural cures. So this was another one that was presented during the meeting about further evidence of a natural cure, which went under a stress test of actually having chemotherapy for a diagnosis of lung cancer without any reactivation, and a very touching video by the woman who has survived this. And finally, a lot of data coming out that looks interesting about the role and the development of broadly neutralizing antibodies, including a really fascinating advance around CAR T cells that could stimulate cells to secrete broadly neutralizing antibodies in an animal model. So exciting stuff that's still happening on this front, and I think we need to keep an eye out for as we go forward. So just to conclude, this was really a fascinating meeting. I learned a lot, and just spending time there was amazing. This is a picture of the sculpture outside of the convention center that I took, and it's really designed to represent transparency via all these triangles, which are all the countries in the world in this hand, apparently, which is supposed to mean that the whole world must fight this disease, which they meant corruption. And Rwanda being a country that has really taken that head on and is recognized for being having a low corruption index. But really, I think was this resiliency, this momentum, and this commitment to not going back despite some of the geopolitical challenges we are facing. So we're going to get back to our questions so we can have some question and answers. I'm hopefully not running too long. So this is our first question again. So remember, in the Breather Plus trial, which of the following was found? Low rates of adherence, most participants with virologic failure had integrase resistance, intermittent TDL was inferior to continuous TLD, or girls had higher rates of confirmed virologic failure. And I think we had a good answer last time. I'm going to close this so I can see the results. In the interest of time, I'm going to put up, oh, have people voted yet? I don't want to preempt the voting.
So everybody go ahead and vote, please.
There we go. So we had an increase in the right answer. It was, I think we had that as a predominantly chosen right answer the first time, but correct answer is C. And the full description of why is here. And really, it was inferior to continuous therapy. We couldn't really appreciate why this was clear. It was not related to adherence. It was not related to demographic consideration. And reassuringly, we didn't see any genotypic resistance. Okay. Post-test question 2, which was quite variable in terms of their initial responses. So in what can be said about results presented at IAS 2025 when switching from efavirenz-based triple therapy to atazanamide lamivudine was resulting in significantly less weight gain. We had option B, continuing integrase strand transfer inhibitor resulted in a similar amount of weight loss as doravirine-based ART. Option C, switching to INSTI with doravirine-based ART. I think Trip talked about this. And option D, whether 12 weeks of liraglutide led to sustained weight loss. Please vote. And good. Well, you did so the correct answer is B. And this is the explanation. And more people definitely move to B. You can read the detailed explanation here, but basically, as I indicated, surprisingly, switch to atazanavir ritonavir did not lead to more less weight gain than dolutegravir. I'm going to not go any further. I'm going to stop sharing because I think we want to have some time for some questions and answers. And I'll turn it over to you, Trip, if you want to guide that.
Okay, great. Marina, thanks for a terrific presentation. Not only highlighting the big, most important studies of the meeting, but also reminding us why Rwanda was chosen and why it's important, and then featuring the really important WHO guidelines changes, which, as I think you said, sort of parenthetically, modernize a lot of what the guidelines are saying and put most of the world guidelines kind of in sync with one another. So we have time for a few questions. And so let me go here. Wow. Can you comment on the need for loading doses with either cabrolpivirine, or lenacapavir? And maybe they mean oral loading doses.
Oh, I mean oral loading. So yeah, so with CAB, that was the original approach, remembering that we did oral loading and then went to injectable. I think the general practice, at least here in Canada, it may differ a little bit in the United States, is that is seldom done anymore. Studies have shown that it's safe to go directly. The rationale for it was really around tolerability, I think, and maybe drug interactions or other things people were concerned about early on. But most people elect to go directly to injectable, and that's what's happening. With Len, there is some dosing orally, and we have some issues around, which were presented at the meeting. I didn't have time to go into them, with drug-drug interactions, including with rifampin. So there was a study presented during the meeting around what you have to do in terms of additional dosing of Len to ensure that you don't have rifampin levels drop during tuberculosis prevention therapy or treatment therapy. So there are some instances in where it's important. Yeah.
Another good question. Given the fact that switching antivirals doesn't seem to help weight gain, does this call into question the fact that INSTIs and/or TAF actually cause weight gain? And you referred to this a bit.
Yeah. So yeah, I mean, and I know the lead of the Do It trial, who presented it, is really the world expert in this, understanding this, and I think we're still unraveling what's going on here. My personal feeling with the bulk of the evidence that's emerging is much of the weight gain that we've observed in these situations relates to coming off regimens that were actually weight suppressive, so efavirenz and tenofovir. And then there's this rebound of weight gain, and then that continues on at a kind of regular weight gain rate that you see in the general population. That said, some of the trials where, particularly in Africa, where it was initiating antiretroviral therapy, we did see these differential and potentially synergistic impacts of using TAF and dolutegravir together, especially in women and Black women, where you saw an exaggerated weight gain that seemed to initially persist and continue to increase. And so I can't say that there is no effect of these drugs. And I think we still need to understand better what's happening at a metabolic level. But on balance, switching off of them doesn't seem to help, which is troubling, because then you can't say to people, let's try you. If you gain weight, we'll switch you off and you'll lose it. You can't say that to people. And what option to give them is increasingly difficult. I don't know in the US, but in our country, it's very hard to access the GLP-1 agonists for people for simply obesity, if it's paid for by the provincial governments. So we don't have a lot of treatment options for the weight gain aside from lifestyle recommendations.
Which you emphasized and which, of course, still remain important. In the interest of time, I'll ask you one last question. The Mpox data with tecovirimat, of course, was disappointing to all of us. What do you think the future holds in terms of treatment options for Mpox?
Yeah, thank you for that question. I mean, one of the things we know, we thought, well, maybe it's just too late to start. With all antivirals, really have a narrow window of starting them when you want to treat, for example, with HSV. We saw this with COVID, that you need within 48, 72 hours maximum of the infection occurring to have real antiviral efficacy. So maybe, the median time before people started treatment in these trials is between 7 and 9 days. So maybe it's just too late. However, that being said, the signal is like zero, like really nothing. So it's going to be, I think, a combination prevention. So we have a vaccine that seems to do a good job, at least reducing a severe event, outcomes and preventing infection. And then there's talk about, developing broadly neutralizing antibodies or other immunotherapies, or even using tecovirimat in combination with that, or in a preemptive strategy, as in once someone's exposed, to try to use it early in therapy. And then finally, for the severe cases, those are the ones where we may see a little signal. Combination with other antivirals such as brincidofovir is being entertained. So we're actively looking to see what the next iteration of trials will be.
So Marina, let me thank you again for really a terrific talk, really summarizing things we need to know, and that will be a benefit to our patients based on what we heard at the meeting. We were up to almost 300 people, so that was pretty exciting. A couple reminders just before we conclude. You do need to complete an evaluation to get your continuing education credits, and those should be emailed to you by the end of business, depending on where you live, tomorrow. So keep an eye out for that. There'll be an opportunity to provide some feedback as well. We have a podcast going antiviral. That sounds like a Mike Sag phrase to me. And an important one coming up is something that challenges all of us, which is treating substance use disorder on the inpatient setting. So keep your eye out for that. Rafi Landovitz, world expert in PrEP, will be joining Mike Sag to talk about complicated issues in the management of PrEP. That's later this month on a webinar. So look forward to that one as well. And an upcoming one after Labor Day, update on Hep B cure, the next virus in the target of the cure agenda. David Wiles from Colorado will be the presenter, and Devika Bhattacharya from UCLA will be the moderator. So two experts in that department. Lastly, we'll highlight the conference on bacteriophages, which is going to be held in Washington, D.C. in October, as you can see there, open to abstracts. I guess the late decision abstract, I think late breaker abstract submission deadline is Wednesday, August the 13th. That happens to be tomorrow if you are planning to submit an abstract. And finally, an upcoming course in Chicago, November 18th, which will be live actually. And you can see the agenda here. So once again, I think that's our last slide. Oh, no, one more. Okay. Focus on people living with HIV as they age, a topic important to all of us. Formal course is in development here, a virtual course that'll be December 2nd. So keep your eye out for announcements of this important one. Lastly, once again, Marina, thank you. Thanks to the IAS-USA for organizing and hosting, and thanks to all of you for joining us today.
Thanks so much, Jeff. It was great. Hey.
Bye.
Bye. Everyone's dropping out.